Thank you, Dr. Parjat, for this nice presentation. Now I would like to introduce Mr. Chien Wong, who is a pioneer in endoscopic vitreoretinal surgery for ROP. He works in Great Ormond, Morpheus, and OCL.
Thank you very much for the kind invitation, Professor Bhagat, Christopher Liu, and the panel. I'd like to talk about advances in surgical management of ROP centered on our UK experience and my experiences from running the UK National Centre at Great Ormond Street Hospital. Here are my relevant financial disclosures. So as we have heard in the last talk, ROP can present at different stages, and about 5% of cases can fail anti-VEGF laser therapy and progressive retinal detachment. So stage 4A is MAC on, 4B is MAC off, and stage 5 is total. So I like to, I think our experience in the UK for us has been very informative, and we, in the 10 years preceding my involvement, work was done primarily at Oxford University, whereby they achieve an anatomic success rate of 55%. So in the past, since 2015, the service in the UK and the provision has evolved. And the question is, how will we be able to get from 55% to 88%? So one of the things that has happened is that we're doing these surgeries earlier. So the time to surgery has reduced from 48 to 45 weeks. And even though it's a relatively rare disease, ROP is in its fourth epidemic now, and it is, as we've heard from the last speaker, it's one of the most important causes of childhood blindness, preventable childhood blindness. So in the UK, we are now receiving referrals earlier. How did we manage to achieve that? The screeners and the ROP screeners in the local units and treaters are really the key people, because the best route to an optimum outcome is earlier referral. So we've started engaging people on the ground about potential referrals about what early changes can look like. So the eye on the left here is normal, and the eye on the right, the blood is a giveaway. But if you pay attention to the first order blood vessels coming out of the optic nerve, some of those early changes, once you get used to looking for them, can be identified quite early. So dragging is when the temporal vessels are drawn towards the horizontal midline, so there's flattening of that angle. And here you can see traction retinal detachment in the far periphery. So you don't have to necessarily examine the far periphery in these babies that are moving in the neonatal intensive care unit. You can just look at the posterior pole and look at the angle of the vessels. And when dragging is more severe, the nasal vessels get pulled across the vertical midline as well, as shown towards the temporal side. So what about this case? Here's another example of a case where, is there dragging? Well, there is dragging. It is relatively mild, and it takes, some practice to identify it. But there is some flattening in the first order vessel, and you can see fibrosis there. And this is a case showing asymmetry between the two eyes. The right eye has very subtle flattening of the first order vessel there. And it's only through scleral indentation that early fibrosis and traction retinal detachment is identifiable. However, if you look at the other eye, the dragging is more pronounced. There's greater flattening. The flattening of the first order vessel extends out towards the second order vessel, and you don't need to indent to see the TRD. We are also able to do surgery earlier now in the UK, and the reason we've been able to achieve that is that the referral and the surgical treatment is now coordinated in the UK. We are fortunate to have to be able to arrive at this point where there is buy-in from pediatric ophthalmologists and vitreoretinal surgeons to agree that there should be one surgical treatment center. So, we have access to better access to beds for children for transfers and surgery, earlier surgical access. So why do we continue to get ROP retinal detachments? We've heard a lot about injections and the timing with the last speaker, but one of the foundations of of treatment remains laser. And laser treatment in ROP is difficult, even with experienced treaters. And this here's an example of a case of bilateral stage 4A detachment. And at the time of surgery, the area circled in red is where there were skip lesions in the far peripheral retina where laser was inadequate. And that's easy for anybody to do. So one of the other changes is our surgical technique in the UK has evolved. So in the previous study, vitrectomy would have been combined with lensectomy or buccal. Over the past 7 years, we've been able to move away from that towards vitrectomy alone, and they've all been lens sparing. And I'll show you why we've been able to achieve that. So one of the key challenges of ROP surgery is lens preservation. There's an impact on outcomes. It increases glaucoma risk by up to 9 times, and there's implications on amblyopia and visual rehabilitation. Lens preservation is challenging because with some of these cases, the traction retinal detachment is very anterior. It comes close to the pars plicata. We can't place the sclerotomy safely, and we end up risking iatrogenic retinal break formation, which during trocar insertion, which typically leads to total detachment failure and phthisis. This is very different from adult vitreoretinal surgery. Secondly, there are multiple vectors of traction with these cases, some of which, again, come up very anteriorly, and to be able to visualize and adequately dissect that, sometimes the lens needs to be sacrificed. So here's an example of a child who has a 4B detachment in the left eye. We know that the detachment is highly elevated because these are RETCAM images taken from the posterior segment, and the picture on the right is focused at the highest point of the detachment, and the posterior pole is completely out of focus, so it's highly elevated. So the management historically had been encircling buccal, but that was suboptimal because it only addressed 1 or 2 of the vectors of traction. Vitrectomy is the treatment of choice, but we've heard that safe entry into the eye, something we take for granted in adults, is not straightforward in these children. So we end up having to sacrifice the lens to enable safe surgery in many cases. So here's an example of the standard vitreoretinal approach with a non-contact wide-angle viewing system, where there's the biome, ReSight, and any other system that you'd like to use. So it's a top-down view. The endoscope provides an alternative view. It's from where the camera sits inside the eye and can directly visualize internal structures, such as the pars plicata and behind the lens directly. I'll show you some videos in a moment. So here is that case, the 4B detachment eye. So here's the endoscope view, which is unique. There's clear lens at the top. There's traction retinal detachment coming up towards the lens. We're looking at a 23-gauge MVR blade being inserted through the pars plicata. With the standard trocar insertion technique, we can't do this with confidence. It's essentially a blind insertion. With the endoscope visualization, we can directly guide the passage of this MVR blade in that tight space between lens and retina and preserve both tissues, and therefore avoid a lower risk lensectomy procedure that's required in a conventional setting. Here's an example of another child that have a left eye inoperable end-stage, stage 5 disease. So only eye patient, 4B detachment in the right eye, significant traction with macular rotation, heterotopia. And here's the endoscope view once again. Okay, it's a unique perspective. There's clear lens, normal lens at the top. We've got the MVR blade being inserted through the pars plicata, and the tip is pushing against some white tissues, fibrosis, and possibly retina. So if one were to proceed with that, there's risk of iatrogenic break. So with the endoscope view, we're able to reposition the blade reliably and enter the eye safely, again, preserving both tissues. So in the UK, we've now evolved the technique with simultaneous visualization using both microscope and endoscope views during surgery. So here's an example of the difference between the two views. So here's a 4A detachment MAC-on. On the bottom left is a standard microscope view that you'll all be familiar with. And the visualization of the vectors of traction is very different from the endoscope view on the top right, whereby you can see all the different vectors of traction coming anteriorly, as opposed to the top with the microscope view. Here's another child, a bilateral stage 4A. So the macula is spared, and you would hope for a relatively good visual outcome. The challenge here is that with the microscope view, the traction is very peripheral. You can barely see it. And the only way to reliably relieve all the traction is either do a buckle or remove the lens. With the endoscope view, we can see there's a curtain of traction covering the pars plicata right behind the lens. We can directly visualize that, accurately dissect through that, and we can now see that the traction has been removed, the lens is still clear, the pars plicata is visible, and the underlying traction retinal detachment is safe, and that an iatrogenic break has not occurred. So here's our 6-year data, single center, to show you what kind of results we can potentially get. We use a 2-step trocar insertion technique, temporal approach for maximum surgical dissection, and only air tamponade. We've had 113 eyes and 30 months mean follow-up, so almost 3 years of follow-up. So majority was stage 4A, so we're getting these cases relatively early, so they're macular sparing. Majority have had laser. There is a trend more recently towards more anti-VEGF injections. So overall, final reattachment rate 88%. That's comparable to some other published retrospective series. But the key slide is this. Primary lensectomy was required in none of the cases in this consecutive national series. What about visual outcomes? Well, we were able to achieve perception of light or better in majority of the patients, including in the more severe total detachments, the 4B5s, whereby only the anterior retina is attached where previous laser was done. What's interesting is that with the reading vision, with logMAR 1.0, which is about 660, we were able to achieve about a third in the 4As and a quarter in 4Bs. And why is that important? Because if you look at the ETROP study, which was a landmark randomized controlled trial that determined type 1 ROP and timing of treatment, they had a subgroup of patients that developed retinal detachment. Only 1 out of 16 of the 4A, the MAC-on group, achieved this level of vision, and none in the 4Bs. Complications are relatively low. There are a few eyes that require cataract, all of which were done beyond 42 weeks, allowing for the critical time of visual development. So in terms of lens preservation, we've achieved a high lens preservation rate with primary lensectomy required in 0% of patients compared to some other published series. Very briefly, what about refractive outcomes in some of these kids? What is the risk of myopia following lens sparing vitrectomy, endoscopic or otherwise? We have a subset of patients that have had cycloplegic refraction. We've got 2 relatively matched groups, one having bilateral vitrectomy, the other unilateral. And what's interesting is that we found that there was significant interocular spherical equivalent difference in the eyes undergoing unilateral vitrectomy of 6.8 diopters compared to the bilateral vitrectomy group. With 2/3 of these patients having an interocular spherical equivalent difference of 5 diopters or more. So this raises questions of why is there a difference in myopia in eyes having unilateral vitrectomy? And it raises questions about, well, should we be treating these patients? And if so, what do we do about the post-operative management? How do we modify that as earlier follow-up? And we are still treating these because the natural history of these cases is that in the long term, they can still progress even in the fellow better eye. So in conclusion, we have found in our UK experience, then one of the key determinants of improved outcomes is earlier diagnosis and referral. And that is really one of the key points here, identifying early dragging. And then having a system in place in country to enable earlier surgery. A different visualization approach can be helpful. So endoscopic can be adjunctive, but microscope visualization remains essential. And visual outcomes better than the early treatment in ROP, randomized controlled trial, is possible, achieving the trend that we've shown here. Thank you.